Good. Good. Uh-huh. Anti-Joe is going to be the polymyositis. Anti-Ro and anti-La are going to be Sjogren's. Yeah, Joe and Ro, I know. It's like, who names these things? So anti-Ro would be. Antimitochondrial PBC. Yeah. And the way to remember that is just say my B. My B. And then that gives you MI for your antimitochondrial, and then B because it's primary biliary cirrhosis rather than primary sclerosing cholangitis. Yeah. Mm-hmm. Mm-hmm. Very good. Yeah. Yeah. So the TSH receptor. I don't know why they wrote it out like that, but yeah, it's TSH receptor. Great. It's good. Yeah. Mm-hmm. Yeah. Yeah, yeah, exactly. So microscopic polyangiitis, granulomatosis, yeah. Mm-hmm. Mm-hmm. That's the mixed. Yeah, very good. Very, very good. Yeah. Excellent. Good. So you're definitely good with the markers. And any questions on these? I mean, these are really what you should expect to see on your exam. Yeah. No. Okay. Good. No. No. I think I think you have a pretty good handle on them. Any questions on what we talked about yesterday before we get started on a new case? Mm-hmm. 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 Yeah. Yeah. Exactly. Yeah. Mm-hmm. And so that should be something that they tell you on the physical exam that if the patient has PMR, they're going to say something about that the strength is intact, or they really have to make that clear on physical exam because that is really your one way of knowing the difference between PMR and your or your polymyositis. That there's really not too much else you can go off of. All right. All right. Okay. Good. 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 Okay. So, our next case here, we have a 13-year-old boy who presents to the orthopedic surgeon's office because of right knee pain of 8 months duration. Right off the bat, what sort of things pop into your head for a differential for this patient? Uh-huh, uh-huh. Sure. Okay, good. So the pain is deep and achy and concentrated on the medial side of the knee. Occasionally, the knee buckles while the patient is walking. Until recently, the patient was able to engage in physical activity, but the pain is too severe now. He has no history of trauma or injury, denies numbness, paresthesia is weakness. He also denies fevers, chills, or recent illnesses. On a physical exam, he is an obese, young African American boy in no apparent distress. Patient's right knee appears atraumatic on inspection, no inflammation or effusion. The knee is non-tender. So basically a completely benign knee exam, despite the fact that this patient is having a lot of knee pain. So that's pretty abnormal. That's pretty strange. Examination of the hips revealed no tenderness, but is significant for increased passive external rotation, decreased passive internal rotation of the right hip compared to the left. Okay, so we have a 13-year-old boy, a lot of pain in the knee. When we do the knee exam, we don't see anything at all. Zero, completely benign. And then when we are continuing our physical exam, when we look at the hips, we're able to externally rotate the hip a lot further out on one side than the other. So, differential diagnosis. What are some of the things that pop into your mind could be going on? Okay. Okay. Mm-hmm. Yep, that's fine. Osteoarthritis. Mm-hmm. Mm-hmm. Sure. So what you might have missed when the connection wasn't great was that so he has this deep achy pain on the medial side of the knee, right? That's what he's reporting. However, on our physical exam, we really see nothing. It's atraumatic, no inflammation, no effusion, non-tender. It's a completely benign knee exam. And then when we continue our exam and we examine the hips, what we see is that there is increased passive external rotation. So there's increased laxity in that hip joint. And then there's knee pain, even though the knee looks completely benign. So what might be happening here? Why is this patient reporting knee pain, but on our physical exam, we really see something abnormal in the hip? It's strange, right? So what may be happening is that he has some sort of referred pain where he has an abnormality, some sort of pathology at the hip, but he's feeling the pain in the knee. And that has to do with, where the nerves travel as they go through the pelvis and enter the leg, the inguinal canal, everything like that. That whole area, if there's some sort of abnormality, can cause referred pain, down the line. So other things that we look at for this particular patient, this patient happens to be obese, happens to be African American, and so sort of other things we can consider in our diagnosis. So, but it's kind of hard to say at this point what's going on. Our differential's wide. What can we do for diagnostics to try and figure out what's going on with this patient's hip? I agree. I'm with you 100%. So we go ahead and get an x-ray, and everything is normal. Knee looks normal, but then we see this at his hip joint. What do you think? Is this a normal hip? Is there something abnormal here? Mm-hmm, mm-hmm. It's a bit tougher when you can't see the other side of the hip. But what I'd like you to notice here is that, when you have a hip joint, typically you have the head of your femur, and that we have a little bit of a separation, and then we have the neck of our femur that lines up really nicely. Now here we can see this tiny little triangle between the head of our femur and the beginning of the neck of the femur. And what's happened here is that the neck of the femur has actually shifted in this direction, where they're not perfectly aligned anymore. Okay, and so the head of the femur is still within the acetabulum. It's nicely positioned in the hip joint. However, the neck of the femur has moved a little bit. Okay, and so what's the most likely diagnosis for this child? This is going to be your slipped capital femoral epiphysis. And so here it's really just that displacement of that epiphysis from the femoral neck through the growth plate. And so let me just erase my drawings here, as beautiful as they are. I want to be able to show you everything. Okay, my eraser. Okay, so what I want you to look for on for this particular condition. Number one, if they give you the X-ray, look for this abnormality here. And it may be more difficult to see on your screen. I'm going to give you these slides after we finish, so that you can have a better look for yourself. You can also Google it. There's really nice images. But what you look for is the alignment of the head of the femur with the neck of the femur. This point here should be perfectly aligned with this point here. But you can see that this is vertically displaced and sort of off to the side a little bit. And what's happened is that this neck of the femur has shifted. It's slipped, essentially. Okay. And so there are a few things that can help you land this diagnosis, even if you don't have the X-ray. You're looking for a boy who is obese and is in his teens, okay? And anywhere age like 8 to about age 15 is where this tends to happen. Obesity really seems to be the major thing that causes this particular condition. 60% of the people affected are greater than the 90th percentile. So obesity is definitely that major risk factor. Look for that in the question stem. African American is also sort of associated. Hypothyroidism, GH deficiency, Down syndrome. These are less so risk factors compared to that obesity. Really, in terms of your high yield, what am I looking for on a question stem? You're looking for a teen boy or a preteen boy who is obese and has some sort of painful limp. Okay, so most common presenting symptoms, that painful limp, antalgic gait. Antalgic gait really just means any patient that's walking in such a way as to avoid pain. So like walking with a limp, or sort of changing how they walk on one side tells you that they have some issue on the other side. That's your antalgic gait. So this pain is going to be difficult to localize by palpation. But when these patients have some sort of activity, the pain gets worse. As we saw in our patient, it can be referred to the knee with a benign knee exam. In that particular case, you should really start thinking, okay, that's still okay for malignancy. It's possible to have a malignancy and you can't really palpate it or see it on your knee exam. So that's definitely something that you want to keep in consideration and use the X-ray to rule out. For X-ray, we're going to get bilateral views because this tends to be bilateral. Look for widening, loosening of the growth plate. Acutely, we are going to hospitalize these patients and put them on bed rest until we can get definitive treatment, which the gold standard is pinning that epiphysis to the femoral neck, okay, and making sure that it doesn't shift around anymore. All right. And so, in terms of this particular case, do you have any questions on how to identify this? Yeah, that's a good point too. Yeah. So, having that benign exam and then also having more external rotation. Yep, that's an important point. Yep, good point. Yep, good. So, differential diagnosis of pediatric limp. Again, our mnemonic here is starts hot, and so that goes to septic joint, our tumors, avascular necrosis, rheumatoid arthritis, tuberculosis, sickle cell, slipped capital, Henoch-Schönlein purpura, osteomyelitis, trauma. These are all of the possible things that a pediatric limp could be. And so, in terms of being ready for your exam, be able to sort of say two things about each of these that make them different from the others. And that way you're going to be really comfortable when you get that question stem. Okay, great. Okay, so our next case here, we have a 50-year-old woman who presents to her primary care physician with cold and painful fingers. What do we think of cold and painful fingers? Raynaud's, I agree. In addition to the pain, she has a lump on the dorsal aspect of her proximal carpal phalangeal joint. Since her teenage years, she's always had difficulty keeping her hands warm. Was diagnosed with Raynaud's 5 years ago. Her past medical history is significant for acid reflux, dysphagia, stomach ulcers. Has a long history of joint pain. Was previously given the diagnosis of fibromyalgia. Okay, so with this constellation of symptoms, what are some of the things that pop up on your differential? Yeah. Right. Yeah, yeah. Good. Good, yeah. So I fully agree with that differential, especially putting scleroderma first. Having, Raynaud's plus some sort of esophageal issues could be, you could have the system-wide scleroderma, or it could just be a CREST syndrome where we're just having those 5 manifestations. Either way, it definitely seems most likely our diagnosis. So next best step. Good, yeah, blood work. And what sort of things are you looking for in blood work? What do you want to see if it is scleroderma? Yep, good. Right. Good, yeah. Good. And so that absolutely, for lab work, let's look for that scleroderma. And in terms of your physical exam, what sort of things are you looking out for, other manifestations of scleroderma? Nope. Oh, the gratin. Oh, yeah, the gratin papules. Yep. Yep. You're stuck on that dermatomyositis right now. Yeah. So, no, but you are right about this. This lump is something. This is going to be a calcinosis. And yes. Good. Good. Excellent. So if this was just a CREST syndrome, CREST is that calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and so seeing really tightening of the skin on the fingers, and telangiectasias. Okay, and so if it's just a CREST syndrome, we would just see those. If it's scleroderma, we can look for other systemic manifestations. And so we definitely want to do a nice pulmonary exam because there is that pulmonary fibrosis that can occur in scleroderma. And so that's an important other thing to look for. Great. So radiographs of the hands, no arthritic changes, but do demonstrate a large calcium deposit that corresponds to the lump. Lab findings, we have a white blood cell count of 11, hemoglobin of 10, ANA titer is positive, and we have that anti-scleroderma antibody, and so our most likely diagnosis. Good. Good. So, Yeah, that's an excellent question. So, the for the exam, typically you wouldn't be given, both CREST and Scleroderma as answer choices. But if you did, what they would be wanting you to differentiate is in terms of the immune markers. So, anti-Scleroderma antibody is really associated more with the diffuse. Yep, exactly, the systemic form, and so the most accurate diagnosis would be scleroderma. However, in terms of what we can see with our patient, we're really limited and would have to just kind of say CREST for now until we get a CT scan of the lungs to see any pulmonary manifestations to say, okay, this is a diffuse form. You can't really say just from physical exam whether it's one or the other. Okay? Yeah. But typically, you wouldn't have them both as answer choices. That's a little bit dirty. Okay, so scleroderma, systemic sclerosis. Essentially, we have tissue fibrosis and occlusion of vasculature through excessive deposition of type 1 and type 3 collagen. And this is something that sort of gets looked over, is that, yes, we have this tissue fibrosis. That's the thing that's first in our mind. That's what's leading to this esophageal dysmotility, where the muscle in the wall of our esophagus is getting fibrosed. It's leading to, the manifestation in the hands, the sclerodactyly. But there's also this occlusion of vasculature due to that type 1 and type 3 collagen. And that's what makes our diffuse form so important to treat, because it can lead to some serious problems when you have occlusion of vasculature. So we can have this present as CREST syndrome, which is that limited form, or diffuse form, which involves the GI tract, GU, renal, pulmonary, cardiovascular. It can really affect a lot of systems. Female gender and age 35 to 50. Our major criterion for systemic sclerosis is sclerodactyly and skin changes of the entire extremity, the entire face, the entire neck or trunk. Some of the minor criteria in terms of diagnosis include sclerodactyly limited to the fingers, pitting scars, bibasilar pulmonary fibrosis. Okay. We can also further, classify this depending on if it's a localized scleroderma, which would be that cutaneous disease with systemic sclerosis involving internal organs. Not something we can really appreciate on physical exam unless, you hear some rails on the pulmonary exam. It's possible that maybe you can appreciate some manifestation, but you really need a CT scan to determine whether it's systemic or limited. Okay. In terms of diagnosis, ANA is going to be positive in 95% of our patients. Anti-centromere antibody is associated with the CREST variation. Our anti-topoisomerase, which is the anti-scleroderma, is the diffuse version. If we're seeing a patient complaining of esophageal dysmotility, sure, we can do a barium swallow to have a look at what the geography of the esophagus is currently. And for fibrosis, we should follow our patients with pulmonary function tests. Because we are affecting a lot of different organs, just like in lupus, there's a lot of different treatment strategies. So for the arthralgias our patients are going to have, any over-the-counter analgesia is fine. For myositis, glucocorticoids, you're going to find really in most diseases when we talk about myositis, the go-to is going to be glucocorticoids. And then for more severe myositis is when we use these immune suppressing drugs, methotrexate, azathioprine. That's how we reduce the inflammation in our muscle. For pruritus, we can use moisturizers, obviously, antihistamines, TCAs, kind of work at the level of the central nervous system to decrease the amount of irritation from pruritus. Pulmonary fibrosis, cyclophosphamide, another immunosuppressant. Raynaud's phenomenon, the go-to there is calcium channel blockers, right? That's like some step 1 level stuff. But also we could use things like prazosin, reserpine. Topical nitrates is one that's I have seen, I think probably in a UWorld question I saw this once, that you can use topical nitrates. These I haven't really seen in any questions before, but I suppose it's possible. If you have very serious cases of Raynaud's phenomenon that are not responding to medications, you can actually go to the level of the spinal cord and sort of clip some of those nerves to reduce the amount of spasms. For renal hypertension, ACE inhibitors, and for skin changes, D-penicillamine or an immunosuppressant. Okay, so a lot of different medications. Really, we're just kind of have to think about what is our goal, what are we trying to treat here for our patient, what's bothering them the most, and sort of start our treatment there. It's just an image of the sclerodactyly that we see in these patients, as well as some of the pulmonary fibrosis we can see on CT scan. Okay, and so typically on this window, I believe this is a bone window for our CT scan, where some of the bone tissue, more dense tissue, is lighter than tissue that's less dense. And so typically in the lungs, you should see a lot of black spaces, a lot of essentially what is air. However, here we can see a lot of bright white, dense areas, which correspond to areas of fibrosis in the lungs of someone with scleroderma. So high yield points, tissue fibrosis and occlusion of vasculature. We can have CREST form or a diffuse form, sclerodactyly skin changes, these pitting scars, bibasar, pulmonary fibrosis. Look for the anticentromere in CREST, anti-scleroderma in the diffused version, and then we talked about all the different treatment strategies, and we have sort of the high yield version, the high yield drugs that you should know for step 2 listed here. Okay, great. Any questions on our scleroderma? Great. Okay, so I thought we'd break up our lesson here, our cases. We're going case to case to case. Here's a question. If you want to read through it and let me know what you're thinking for the answer. Yeah. Mm-hmm. Good, good, excellent. And just like you said, you're really looking for, when you're having those manifestations of, urinary retention is the most common thing. This guy's not able to retain his urine, but that rectal tone being absent is a really, really red flag, huge red flag. This is an orthopedic emergency. And so what do we think this guy has? If we went ahead and did the MRI, this would be the wrong answer because, this patient needs to go to surgery. But if we did do the MRI, what would you expect to see? I'm sorry? Cauda good, very good. And so this is probably a prolapse disc, right? Because this patient reports that he's been having the pain for the past 2 years. We talked about how there's that annulus fibrosis and the annulus pulposus. We have a weakening in the fibrosis layer that starts to impinge on the spinal cord slowly over time. And then suddenly, when this pulposus actually prolapses out of the disc, is when we actually will see the rapid increase of the symptoms, like we do in this gentleman. The other thing that we can look for here is that this patient has pain as well as decreased strength. And so from that, we already have a pretty good idea that this is due to a disc prolapse. Okay, and then an MRI should probably confirm that. The other question here is steroids. This is a current debate in the field of neurosurgery, whether or not to give steroids when you have a patient that has some sort of trauma to their spinal cord. Some surgeons do it, some surgeons don't do it. There's been some studies that show it improves outcomes, but it's not law yet that steroids should be given before surgery, although it may be someday. Okay. Great. Surgery, great. Okay, so we have an 84-year-old woman who presents to her PCP with muscle weakness and a crusty, scaly rash on her knuckles and over her eyelids. So, what are some things that pop to your differential there? Gotta be. It's gotta be. So for a couple of months, she's had difficulty getting out of a chair, but attributed it to aging. The rash developed 2 weeks after visiting a self-tanning salon and is extremely pruritic, itchy. She has tried taking antihistamines, applying moisturizer, but reports no relief. The itching is so severe, it wakens her at night. She denies fevers, chills, changes in detergents or creams. She's taking no medication except for the antihistamine. She's afebrile with a heart rate of 70, blood pressure of 110/80, respiratory rate normal. Notable findings include foliaceous papules. Oh my God, talk about buzzwords. Over the MCP joints of her hands and upper eyelids, and a rash with a shawl-like distribution over her anterior neck, upper chest, and back. So yes, I agree with you. I think that this is probably dermatomyositis. So what's our next best step? How could we confirm our diagnosis here? Antibodies a great next step. Yeah, very good. Now, that is a great way to find our diagnosis, but what is our gold standard? What is the way? Biopsy. Good. Yeah. Very good. But that's not the next best step. Okay, don't get me wrong. That's not what you would do next. That's just if you really need to confirm this diagnosis, and you can't do it via antibody. I suppose you could do a biopsy. So relevant labs, elevated ESR, ANA positive, and then you can see that CPK. This is something that I didn't mention before, that patients with dermatomyositis and polymyositis, because you're having inflammation of the muscle, you will have a positive CPK in these patients. Okay, and so great. So polymyositis, dermatomyositis. We'll start with polymyositis. This is going to be a progressive systemic connective tissue disease with immune-mediated striated muscle inflammation. Okay, dermatomyositis is really just polymyositis with that cutaneous involvement. So before we go on here, let's just talk about where's the inflammation. Why is it that in one particular disorder we see inflammation of the skin, we see these papules and all the shawl, everything else like that, and then in the other we don't? So it's really the location of the inflammation has that impact on the clinical presentation. So when we talk about dermatomyositis, we have antibodies that are attacking our muscle, and they attack the perimysium of the muscle. That perimysium is that layer around the muscle. I don't know if you remember from maybe histology class where we talked about the structure of a muscle, but essentially you have a lot of cords of muscle fibers. Those muscle fibers all come together to form a muscle, and that's surrounded by perimysium. So when you have that inflammation of that protective layer, that is going to cause some atrophy of the muscle. Perimysium is closer to the skin physically, geographically, closer to the skin, and therefore we see cutaneous manifestations, okay, giving us that dermato of dermatomyositis. One thing to remember also is that this tends to be associated more with a CD4 mediated and complement mediated inflammation, okay? So that's sort of the arm of our immune system that's being activated here. Polymyositis, go ahead. Yeah, very good. Yeah, so someone with HIV wouldn't have the CD4 lymphocytes to really have this autoimmune focus. Yeah, absolutely. That's a good point. Yeah. So polymyositis here, this is going to be T-cell driven instead of antibody driven. T-cell driven autoimmune disease characterized by endomysial inflammation. So now, instead of the lining on the outside of these muscles, now it's the endomysium, the inner layer of protective fiber on the muscle fibers themselves. Okay, so this endomysium is further from the skin and therefore has no cutaneous manifestations. And this is associated with CD8 lymphocytes, directly damaging the endomysium themselves. Okay, and so while clinically, the weakness that these patients feel is very similar between the two disorders, there's actually a slight difference in the pathogenesis of how they develop their clinical condition. So going back into what we see clinically, symmetric progressive proximal muscle weakness leading to difficulty squatting, kneeling, rising from a chair, climbing stairs, really anything that's using some of those big muscle groups is where your patients are going to have a lot of symptoms. You can also see difficulty brushing their hair, raising their arms above their head, because we have to use our delts and our lats for that. And so, a lot of these symptoms are due to those large muscle groups. There's all these buzzword rashes: heliotrope, foliaceous, the Grotten's papules on the hands, the shawl on the neck and chest. And I think you can really close your eyes and picture what this patient looks like from all the pictures that we've seen through studying for Step 1 and through our classes. It is going to be photosensitive, and so when we think about the patient in our question stem, she reports that she started having these symptoms after going to a tanning bed. Okay, and so that photosensitivity is an important aspect too in dermatomyositis. Increased serum CK, increased anti-Jo antibodies. If we do that muscle biopsy, we can look at where, in terms of the fiber, the inflammation is, and in terms of really targeting our diagnosis, dermato versus polymyositis. Is this necessary? Not really. If you can get the diagnosis from serum CK or those anti-Jo antibodies, you're not going to go ahead and do the biopsy anyway. If these things are equivocal, you're not too sure, or maybe if your patient is not responding to steroids, and now you're thinking, okay, is this maybe a thyrotoxicosis, where we're having muscle weakness due to lack of your thyroid hormone. Some of these other manifestations that involve the muscle. Okay, now we'll do a biopsy to really make sure that we are treating the right thing. High-dose systemic steroids for all patients with myositis. That's going to be your first line. For primarily skin manifestations of dermatomyositis, you can just give hydroxychloroquine. Okay. That handy anti-malarial drug. All right, and so that's sort of the big long short of dermatomyositis and polymyositis. In terms of being able to differentiate fibromyalgia, polymyositis, and polymyalgia rheumatica, here's another chart that I probably shouldn't have that really breaks it down between these three. What are the things you're looking for? So fibromyalgia, we talked about this. Really, in terms of fibromyalgia, think of it as a psychiatric diagnosis instead of a musculoskeletal diagnosis, because that's what it is. So we're looking for young to middle-aged women, chronic, widespread pain, not in a typical distribution, sort of here, there, and everywhere. Fatigue, impaired concentration, it's considered a fibro fog. Right, I told you to think of these patients as fibro fog with this, just difficulty concentrating, forgetfulness, things of that nature. There should be some tenderness at trigger points, and so the mid-trapezius costochondral junction. There's actually a chart of all of the trigger points for these patients that, for whatever reason, it's sort of idiopathic why they have more pain there than in other places. But in terms of diagnosing this, we're looking for greater than 3 months of symptoms with widespread pain index symptom severity score. This is an actual diagnostic tool that we can use, and we look at the number of trigger points that they're positive for and for how severe the pain is at those trigger points, and that kind of gives us our diagnosis. You don't need to know that particular clinical tool. You'll be able to have that when you are a practicing clinician, but just know that this is sort of how it's diagnosed, and keep that in mind when you're trying to diagnose via question stem. Okay. Normal lab studies is another prevalent thing with fibromyalgia that can help you in terms of determining what is going on with your patient. Polymyositis, really the name of the game, like you told me earlier, is going to be weakness. Okay. The pain is really going to be mild or absent. The muscle enzymes we can look for, autoantibodies, and then biopsy will be our gold standard for diagnosis. PMR, we're looking for a little bit older patient. Systemic signs and symptoms, stiffness. Look for your patient to be having a low fever. Weight loss is another big part of this disorder. And here we're looking for stiffness and maybe possibly some pain, but really stiffness is the primary part of our picture. In the shoulders, hip girdle, and neck. Okay, so sort of these primary parts of our body that hold us all together is where we see that stiffness. There is this association with GCA, then we need to rule out. Look for ESR, CRP, and rapid improvement with glucocorticoids. Okay, low dose glucocorticoids, we should be good to go. All right, great. Yeah, low dose glucocorticoids. Is it? Hold on, let me pop back to the slide just to make sure. Okay, just making sure. Yeah, exactly. Yeah, so polymyositis, we want to do high dose corticosteroids, really just bathe this person in corticosteroids right off the bat, and wait for the resolution of symptoms. With PMR, PMR is really something that would probably resolve on its own, but we give glucocorticoids to improve these signs and symptoms and really just improve our patient's quality of life. Okay, but exactly, and if that's very good. Okay, excellent. All right, so we have another question here if you want to read through it and let me know what you think for possible diagnosis. Yeah, great. Yeah, definitely SLE. She's got all of these, very typical manifestations: the pitting edema in the lower extremities, swelling of the joints, the ulcers in the mouth, and then when we look at the white blood cell count, there's a little bit of leukopenia, and so a little bit of thrombocytopenia as well. Platelets of 82. That's below our normal limit, and so definitely this looks like SLE. Great. So what is Behçet disease? What is this thing? A Behçet disease? Now, Behçet disease is really, all you're looking for in Behçet disease is your patient is completely normal, but then they open their mouth and there's just ulcers everywhere. Just like a disgusting amount of ulcers. That's Behçet disease. It really only affects the mucous membranes. You can also have these ulcers in the GU tract. Less common, but if you see a patient with a lot of oral ulcers, the things you think of are either oral herpes or Behçet disease, and Behçet disease just happens to be an autoimmune cause of oral ulcers. Okay, so great, that's Behçet disease. Definitely not what our patient has. What about reactive arthritis? Mm-hmm. Good. Good. Excellent. Yeah. So they were looking for, it could be sexually transmitted or chlamydia. It could also be something like Campylobacter, which would be a GI infection, right? And that can also result in reactive arthritis. And this also, in terms of things we have to know for step 2, this has that HLA-B27. HLA-B27 connection, right? Yeah. Yep. Very good. Okay, next we have a 23-year-old Asian American woman who presents to her PCP with cold hands, increasingly frequent episodes of headaches, and lightheadedness. Okay, so what are some of the things that pop into your mind with this type of patient? Yep, good. So we'll throw up Raynaud's and Scleroderma, that whole manifestations, and then having these headaches and lightheadedness. We think probably something vascular going on, right? Yeah, great. So she reports coldness in her hands is associated with numbness, tingling, loss, and sensation in her arms. 2 days ago, while reading a book at her desk, she reported seeing flashing lights followed by loss of vision that lasted about 15 seconds. She denies head trauma, fever, night sweats, chills, weight loss. She's not taking any medications aside from pain reliever, Tylenol. On physical exam, she is febrile. She has a pulse of 65, elevated blood pressure, 140/90 in a 23-year-old. Interesting. And a respiratory rate of 12. She has carotid bruits, faint pulses in her arms bilaterally. Hands are cold, cyanotic nail beds. Lungs are clear. Heart has regular rate and rhythm. Abdominal exam is unremarkable. Okay, great. So, differential diagnosis. What do you think is going on with this lady? Yeah, definitely. Absolutely. So this loss of vision, when you have a temporary loss of vision, that's something called amaurosis fugax. And this typically means that there is some kind of inflammation or blockage going on in the ophthalmic artery. Okay, and so GCA absolutely can lead to that. Temporal arteritis can lead to that. There's also Takayasu arteritis, which is something we can think about since it is an Asian American woman. Okay. Anything else? Great. So next best step. Sure. Okay. So Takayasu arteritis. Here, this is just that inflammation of large, medium arteries. When we think about, what the patient population, it's typically going to be a young Asian woman. Our patient had these bruits in her carotids, as well as that elevated blood pressure, decreased pulses in her upper arms. So guess what? Those are all branches of the aorta, right? That's going to be our brachiocephalic, our carotid, and our subclavian. Every one of those branches was affected in this particular patient. And so that should definitely point us in the direction of Takayasu. So arm claudication, Raynaud's, constitutional symptoms like fever, weight loss. And then on our physical exam, hearing that carotid bruit, in someone that's so young, should really point you in this direction. Asymmetric upper extremity blood pressure measurements, faint peripheral pulses are sort of how we would diagnose this. We would confirm this by arteriography using a little bit of dye, and what we could see is irregular vessel walls, narrowing or occlusion of the aorta. In terms of treatment, we're just going to go ahead and dose her up with a bunch of steroids, and that should induce a remission. And typically, after a remission, it doesn't really come back. And so, really, the goal is just to induce that remission. Okay. So this one is a little bit more vasculitis. Now that I think about it, rather than MSK, we're kind of like venturing out of MSK here, but it is sort of there's a lot of overlap in these two areas, especially when you think about so there is a lot of overlap. One of the things with Takayasu arteritis that we want to avoid, and why we do high dose steroids rather than low dose, is there's a risk of stroke for these patients because you're having all of that inflammation in the carotid. That your patients could possibly have a stroke. And so that's why we do high-dose steroids, potential complication. Okay, very good. Okay, so we have another question here. If you want to read it over and let me know what you think. Okay, good. Excellent. So you know the rule then. Whenever you have a hot joint, you have to just go ahead and aspirate it. Even if you know that you have a pretty good idea that it's just gout, because gout and septic arthritis they look so similar. It's so difficult to tell the difference between them on physical exam. And septic arthritis is one of those things where if you don't start antibiotics right away, you can have destruction of that joint tissue, and your patient can end up with much worse outcomes. So this is why we do a joint aspiration with synovial fluid analysis, because if it is some sort of bacterial cause, we can start antibiotics right away, versus, if it's just uricemia, we can, reduce uric acid levels in other ways, right? Do an allopurinol. We can give endomethacin. There's a lot of good ways to reduce uric acid levels. But for this particular patient, we don't know for sure that it is going to be gout. So let's do that joint aspiration and make sure. Okay, very good. Great. So next, we have a 13-year-old boy who presents to the orthopedic surgeon with progressively worsening right leg pain of 6 weeks duration. Patient says the pain began after being tackled in a football game 6 weeks ago. Since then, the pain has not improved despite rest, ice therapy, and ibuprofen. Pain increases with activity. In addition, he's noted a lump behind his knee after the game. Okay, not good. On physical exam, there is a small but palpable mass in the popliteal region. In addition, there's a slight decrease in passive range of motion in the right knee compared to the left. The patient has full strength in all extremities, exhibits no neurological deficits. Differential diagnosis. Wait, sorry, what did you say? Oh, Baker cyst? No, okay, yeah. Yeah, that's true. So, we have a child with leg pain, knee pain for 6 weeks. What are you thinking, like, if that was all I gave you, what would you, like, what things would you want to have on your differential? Trauma or malignancy. Okay, good. Yeah, that's what I wanted you to say. Good. So, definitely things we're concerned about. It started after trauma, and so that's one area, but also we want to be concerned about malignancy. And going through this lecture today, it's like never been malignancy. So I feel like you want to keep on thinking of malignancy though. So with this boy especially. So next best step, what would you like to do next? X-ray, great. So we do an X-ray, and what we can see is that a large lesion, osteoblastic and lytic changes. Posterior aspect of the supracondylar region of the femur. There's a prominent elevation of the periosteum. So definitely malignancy, yes. So which malignancy would you? For our options, right? We have chondrosarcoma, osteoblastoma, Ewing's sarcoma. What particular malignancy would you most likely attribute, considering this X-ray image? Ewing's sarcoma. Okay, so the key here between differentiating between Ewing's sarcoma and osteosarcoma, there's two big things you can look for. Number one, you can look for this. This particular sunburst changes is what we see with osteosarcoma. And osteosarcoma tends to occur, in the area of the lower femur, okay? And so it would originate somewhere in this area. Ewing's tumor tends to originate somewhere within the shaft of the femur itself. And in that one, we look for more onion skinning type pattern on X-ray. Okay, great. So osteosarcoma, this is our second most common primary malignant tumor of bone. Our first most common primary malignant tumor of bone is multiple myeloma, in case you're curious. The most common in the metaphyseal regions of the distal femur, proximal tibia, proximal humerus. Okay, so we're thinking right in the area of the knee and then right in the area of the shoulder. The most common place for it to metastasize is going to be the lungs. And then there's also that connection with Paget's disease, that you can have Paget's disease for a long time, and that can turn into osteosarcoma. It presents with this progressive and eventually intractable pain that's worse at night. Bone pain is horrible. Anybody that has to go through that, I feel so bad for them. Constitutional symptoms: fever, weight loss, night sweats. And then at the site of the tumor, you can see some enlargement and some erythema to the skin. And on our patient there, we were able to palpate a small nodule right there in the popliteal region, which is probably that tumor growing. Radiographs, we can look for Codman's triangle, where as the femur sort of tapers at the end, femur kind of tapers like this. If we have a tumor growing here in the metaphyseal region, what's going to happen is that the periosteum, or the lining of the bone, is going to start to raise off of the bone itself. And this is our sort of Codman's triangle. If you put an extra line here, you would have a triangle, and that is indicative of an osteosarcoma. And that really can help you remember that osteosarcomas tend to come from this area of the femur. Is that because of that tapering, that's how you get the triangle. Okay. Or a sunburst pattern, which is what we saw in our x-ray. This is the sunburst pattern where you have all of these lines of neoplasia or tumor growth or whatever it is, sort of bursting out from the femur itself. MRI and CT can facilitate the staging, showing that soft tissue, bony invasion, and plan for surgery. The goal here in terms of treatment is to do anything to spare the limb. We don't want to remove the limb, so we want to try and do some chemotherapy, but there is that high risk of metastasis to the lungs, okay? And now you're dealing with a really deadly diagnosis. So you want to attempt limb-sparing procedures, so methotrexate, doxorubicin, cisplatin, ifosfamide, these big gun anti-tumor drugs. But amputation may be necessary in the long run if it does not respond to these particular drugs. Okay? Great. So in terms of identifying what is the cause of your patient's tumor, really looking at the femur itself is helpful for diagnosing. So we said osteosarcoma we can see in the metaphysis of the femur. And the way we remember that is because that's the only place we could really have a Codman's triangle, because of the tapering of the metaphysis, metaphysis, whatever you call it, that's how we get the Codman's triangle, when the periosteum starts to lift off. Ewing sarcoma we see a bit higher in the diaphysis, in the shaft of the femur itself. And then chondrosarcoma is usually a smaller lesion that's located in the shaft of the femur. Okay. Any questions on osteosarcoma? No? Okay, great.